Today we have the pleasure of hosting Dr. Charles Shapiro for a talk on cancer survivorship. Dr. Shapiro is a professor of medicine in the Department of Medicine at the Icahn School of Medicine in Mount Sinai. He received his medical degree at SUNY Buffalo School of Medical and Biomedical Sciences. He completed his internal medicine training at Temple University and fellowship in medical oncology at Israel Deaconess Medical Center, Harvard Medical School. He's a nationally recognized leader in breast medical oncology and research, and he joins the faculty at Mount Sinai from Ohio State University, where he was the section chief of breast cancer, the breast research program leader, and the director of breast medical oncology. At Mount Sinai, he serves as the co-director of the Dubin Breast Center, director of translational breast cancer research for the Mount Sinai Health System, and the director of survivorship program at the Tisch Cancer Institute at Mount Sinai. Please join me in welcoming Dr. Charles Shapiro.
Good morning. It's a pleasure for me to accept the invitation from Dave and the Chiefs to talk about a subject I truly love, that is cancer survivorship. Now, my title is Cancer Survivorship in Breast Cancer because most of the work is done in breast cancer, most of the funding has been done in breast cancer, but I'm using breast cancer as a paradigm for other solid tumors and liquid tumors. I have no disclosures to make. So let's start with a case presentation. A 40-year-old woman with a stage 2 T1N1, that means N1, 1 to 3 positive nodes, breast cancer treated with adjuvant chemotherapy. And we can ask two questions. What is the probability of early menopause this woman will experience? And what is the probability of personal cure? That is dying of something else, not breast cancer, and that's a win-win. So the answers are 50 to 60% of women this age will go into permanent menopause due to direct effects of chemotherapy on the ovaries. And what is the probability of personal cure? About 85%. So long-term survivorship in this woman with node-positive disease and early menopause. So on everybody's to-do list is beat cancer and live, hopefully, a long life. So survivorship as an academic pursuit is on the radar screen. And it's data like these that suggest that death rates are decreasing. This is a rather famous paper by Don Berry and his group. Don Berry's a statistician in the New England Journal in 2005, where he modeled decreasing deaths from breast cancer. And it turns out that the combination of screening, early detection, adjuvant therapy, both of them combine to decrease the death from breast cancer. So it's mathematically, he modeled this, various models, but it's consistency in terms of decrease the deaths due to screening and adjuvant therapy. This is an old data from the Sloan Kettering Cancer Center. This was done in the late 60s, early 70s. Stage 1 and stage 2 breast cancer patients treated virtually all with mastectomy, and less than half got adjuvant therapy. And you can see even then long-term survivorship. And if we repeated these data in the modern era now, the survival rates 20 years and beyond will be even greater. So I did a thought experiment, or a quick and dirty experiment. So I measured I collated the number of cancer survivors, 1970, about 4 million cancer survivors, and there's been a logarithmic growth in cancer survivorships through 2010. In 2015, there's about 15 million cancer survivors in the US. Now, when Nixon declared war on cancer, I searched the literature for the keyword survivorship, and there was one paper in 1970 that had the keyword in the title survivorship. And like the incidence in rising cancer survivors, there's been an explosive incidence in the academic papers, and this is still an upward slope. These are 2008 data. I'm sure that 2015, there's over 10,000, maybe 20,000 papers written in survivorship. So it's a new academic discipline, fairly recent discipline, but it correlates with the increasing numbers of cancer survivors over time. So it begs a myriad of questions. And you know some of these questions as well as I do. What is it, survivorship? What is it? When does it begin? Who is going to do for it? And more importantly, who is going to pay for it? What are the best models? What are the best methods to disseminate guideline recommendations that we spend a lot of upfront time in formulating these best practice or evidence-based guidelines, and how would we ensure that the guidelines are making impact? Well, survivorship is many things to many different people, but I think my own definition is encompasses the totality, and that is that empowering individuals to chart their own path to wellness after cancer treatment. When does it begin? According to the National Cancer Institute, at the time of diagnosis, but functionally it begins after treatment. And why is it important? For obvious reasons. 15 million survivors in the US today, primarily consisting of breast cancer, colorectal cancer, and prostate cancers. But by 2020, with 20 million survivors, 2/3 of them are over 65. So geriatric survivorship is the new coming wave. So I'm a clinician too. I see patients, and in a 15-minute follow-up exam, my answer to these questions is no. You have time to adequately screen for the stress and depression, discuss vasomotor symptoms, discuss sexual dysfunction, discuss bone health, and et cetera, et cetera. So we're really, survivorship encompasses so many things that we don't do routinely. And of course, there are other people to do this. The stress screening and the treatment summary and individualized care plan are part of the COC, or Commission on Cancer requirements, starting in 2015, that every patient will have the stress screening and an individualized treatment summary and care plan. So there's dual aspects of survivorship. I think of it in two ways. There's the treatment-related complications. Some of the common ones are peripheral neuropathy, fatigue, vaginal dryness, particularly on aromatase inhibitors. If you ask women on these drugs that are routinely given to postmenopausal women who are estrogen receptor positive, if you have vaginal dryness, 100% of them say yes. And it varies in degree from barely symptomatic to real problem, painful intercourse, and so it's really a spectrum. So there's the rare side effects as well. Congestive heart failure after anthracycline exposures, or rarer still, leukemia and myelodysplastic syndromes related to anthracyclines or alkylating agents, and this tamoxifen-induced endometrial cancers and venous thrombosis. But there's a whole another side of the equation, and that is improving health behaviors. Physical activity, increasing physical activity, weight management. It's so important. A position paper came out on obesity. And obesity is a risk factor for getting breast cancer, but when you have it, it's also a poor prognostic factor. And this extends to colorectal cancer and a few other cancers. Nutrition counseling, smoking cessation. And when faced with a crisis, the term has been coined, that's a teachable moment. There's receptivity to health-changing behaviors at that moment. Whether it lasts beyond the treatment period and the immediate crisis is another question, but at least there's a teachable moment. So there's varying definitions of cancer survivorship. In pediatrics, it's individuals without evidence of disease recurrence from the original primary tumor. Adult is more encompassing. Individuals living after or with cancer, their families as well as their caregivers, from the day of diagnosis through the remainder of their lives. So it's a broader definition. It includes family members and caregivers in that definition. Survivorship care, why now? Well, it's obvious, rapidly growing population, promotion of optimal health, and expectation of better quality of life, and in general, greater emphasis on patient-centered issues. So let's get into some of the survivorship issues. There's long-term and late effects. A long-term effect occurs during chemotherapy, and it extends after chemotherapy, and a late effect occurs after the treatment. And sometimes a long-term effect can lead to a late effect. The classic example is estrogen deprivation due to early menopause causing bone loss can result in some women with subsequent osteoporosis, a late effect. So there's a relationship between long-term and late effects. Follow-up guidelines, a lot of follow-up guidelines. The three most recent from ASCO are depression, fatigue, and peripheral neuropathy. There's other guidelines. There's an osteoporosis bone health guideline coming up. There's a guideline and expert panels convened to make recommendations. The duration of oncologic follow-up care and the integration between oncologists and primary physicians is key. We know from data that when oncologists do the medical follow-up, they do a crappy job in terms of less routine preventative health maintenance. There's data on this. The oncologists give less flu vaccines, less colonoscopies. So each of us, the oncologist and the primary care doctor, have separate strengths to combine forces and give the best possible care to the survivor. And there's communication and providers. The biggest complaint we hear from primary care physicians is, I send my patient, and then my patient disappears, and I never get notes, and then he comes to see me, and I'm in the dark, and so forth and so on. And knowledge base of both oncologists and primary providers, we've got to provide knowledge, both groups. So this is a survey about 10 or 12 years old, but it's relevant today. It's a Lance Armstrong Foundation survey. 70% of people, survivors, reported that their oncologists did not offer support in dealing with health problems related secondary to cancer. Let me read that again, because it's astounding. 70% of cancer survivors reported their oncologist did not offer support in dealing with health problems secondary to cancer. 30% of them reported the oncologists were willing to talk about health problems, but they didn't have the experience. They didn't know what to tell the patients for these various health problems. So that's astounding, and it's pretty much true today. Further going on the survey, 53% of survivors reported secondary health problems. The list is here: chronic pain, sexual dysfunction, relationship difficulties, fertility issues, fear of recurrence, depression, anxiety, and financial and back-to-work issues. And 49% of survivors reported their non-medical cancer needs were not met. Again, emphasizing on this marriage between the primary care provider and the oncologist, each contributing strengths and participating in the care, optimal care of that patient. So I was privileged to talk on, among other topics, on infertility and the data that oncologists do infertility, ask the right questions. So there's guidelines from ASCO in 2006 and recently updated in 2013. And for women ages 18 to 40 and men 18 to 50, among the key recommendations are discuss the risk of infertility related to chemotherapy and discuss fertility options and or refer to a reproductive endocrinologist or some other specialist that can discuss these issues. So the ASCO, American Society of Clinical Oncology, COPE project, Quality Oncology Practice Initiative. It's a voluntary process where practices throughout the country, both academic and community-based, submit their medical record data. And it's a way of primarily seeing how good we're doing in guideline recommendations, following the recommendations. I just want to highlight the question 33, which is, did you discuss the risk of infertility with chemotherapy? And question 34, if you did discuss it, did you discuss the fertility options and refer to a reproductive endocrinologist? And these are the data that I obtained from COPE. So question 33, infertility risk prior to chemotherapy discussed. And this depends on documentation of the medical record. What's in the medical record? So you can see 20% documented a discussion in 2009 and topped out at 35% in 2014, documenting a discussion about the risks of infertility related to chemotherapy. The next slide shows you question 34. Did you discuss fertility options or you referred interested parties to fertility specialists? 12% in 2009 and 22% of medical record charts documenting the referrals. So how about that? So survivors have unmet needs. COPE has limitations. It's voluntary participation. It depends on documentation. And you know, if you don't document, you don't do it. You might have done it, but it doesn't count. Nobody knows you did it because you don't document. And fertility COPE results, the good news is the trends are improving. The bad news is the majority are not having the discussion and or not documenting. And I think it's a little bit of the latter, but more so of the former, not having the discussion. So in our own house, we have a lot of work to do in terms of improving fertility and other aspects of survivorship. So I want to bring up a second key point. Not all survivors have the same needs. And we did a study when I was in Ohio. Columbus, Ohio, location of Ohio State University, where I used to work, is the 16th largest city in America. Many people don't know that. I don't know why you would want to know that, but nonetheless, it's the 16th largest city in America. And Ohio has Holzer County, which is in Appalachia. And Holzer Medical Center is the quote-unquote cancer center in this region. Just a way to put the demographics of the population, and this was a survey in 2008. And the U.S. population is here, the Ohio State, Ohio population, the state population, and it's Holzer County. You can see the household income, per capita income, unemployment rate, and poverty rate are all lower, and the unemployment rate is higher, and the poverty rate is higher in Holzer County relative to Ohio and the general use U.S. population. So people live in Holzer County are economically disadvantaged. So here's a convenience survey. We had a group, Survivors Day, and we have people from Holzer and OSU, Ohio State University, 107 and 98 respectively. And they were not different in age, they're not different in race or Caucasians, they're not different in sex, but they were different in education beyond high school and income less than $40,000. 63% of the Holzer survivors had an income reported less than $40,000, and 27% had education beyond high school. The results of the survey, the number one thing was fear of the cancer coming back. That was universal. But other things differed in these two populations. For example, the Ohio State survivors were more interested in exercise and healthy diet, whereas the Holzer survivors were more interested in financial concerns. And this was the recession, the beginning of a recession. There was a gas crisis, gas prices were higher, and people in Holzer County were worried about having enough money to pay for gas to go to the doctor and other things. And psychosocial concerns were more prevalent in Ohio State survivors. Let me take you through another aspect of the survey that's really important. So this is percent, and these are various referrals that survivors could access in both systems. And this is fatigue management, psychosocial counseling, exercise programs, nutrition programs, financial programs, stress management, and general support. And we asked whether the survivors were referred to these various services. With the exception of counseling, less than 20% of survivors were referred to this service. And that's underutilization, in my view, about survivorship and the various services. But we asked a different question, another question. Would you go if you were referred? And that was really surprising to us, because more than double the amount of survivors would go if they were referred to various services. So again, within our own house, these services are available. It takes a physician to refer them to services, and we're not doing the best job we could in terms of referral basis, referral to the survivors. So what do we do with this survey? We translate it into action. We develop programs and classes on the value of diet and exercise, exported and tailored to Holzer survivors. And tailoring is key. You got to tailor to the racial, ethnic, and demographic group you're dealing with. Increase emphasis on providing psychosocial support and financial support. And projects initiated from this survey were enhancing patient-doctor communication and depression screening. All survivors don't have the same needs, and the needs may change over time. Your needs 6 months post-treatment are very different, can be very different than your needs 6 years after treatment. And the context of life is important. Who the person is, where they live, what resources they have, their racial and ethnic background is all important in considering the needs of survivors. They're different, and different times they have different needs. So let's turn attention to some long-term effects, symptoms that occurred during breast cancer treatment, primarily chemotherapy: fatigue, sleep disturbance, Cognitive changes, depression and anxiety, and pain and neuropathy are some of the long-term effects. These can lead to late effects, and I'm particularly going to concentrate on neurocognitive function. Our patients have been telling us for years about this phenomenon of chemo brain. It's a symptom cluster of memory problems, attention and concentration problems, and language difficulty, word finding difficulty, or mispronouncing words. But factors affecting cognitive function can be many, and that complicates the relationship between the causation of chemotherapy causing this problem and other factors that are common in breast cancer survivors. For example, fatigue, depression, anxiety, stress, pain medications, other physical illnesses, all confound the study of neurocognitive dysfunction related to chemotherapy. And a critical aspect is there's often no time for the baseline assessment of neurocognitive function. Post-chemotherapy is usually when it's done. What about pre-chemotherapy? What these ladies were like pre-chemotherapy? Well, that's fraught with problems because they've just got a breast cancer diagnosis, and there's stress, anxiety, perhaps depression surrounding that. So the baseline, timing of the baseline assessment is not ideal in any circumstance. And all of the above complicates the study of this neurocognitive dysfunction in women receiving chemotherapy. So pattern of cognitive dysfunction, not everyone's affected. Our best estimate are 15 to 20% of patients will have real cognitive changes related to chemotherapy. The problems may come and go, good days and bad days, and it often is worse when multitasking, under stress or deadline pressure, you're fatigued, you're tired. These problems seem to come out. Nobody knows what causes neurocognitive dysfunction. Here's a model, proposed model, and there are various causes one can invoke to relate to neurocognitive dysfunction after chemotherapy. So the therapy itself, it causes inflammation, vascular injury, hormonal alterations, meaning androgen deprivation in men with prostate cancer, estrogen deprivation in women with chemotherapy-induced ovarian failure or on aromatase inhibitors, which drive postmenopausal estrogens lower. There's metabolic abnormalities and so forth and so on. There's a big, we think, but clearly poorly defined genetic component. It has to do with, we think, susceptibility to who gets it, who develops neurocognitive function. You might metabolize certain drugs based on your polymorphisms differently, so that's a consideration, and there's been some work on that. And the cancer itself can contribute, either directly secreting cytokines or revving up the immune system to secrete cytokines. All of that can contribute, we think, to altered brain function and neurocognitive dysfunction. But we don't know what causes neurocognitive dysfunction, bottom line. So it usually improves. This is one longitudinal perspective study where the baseline was after chemotherapy, and they followed them longitudinally for 1 to 2 years. And these are a bunch of instruments, validated instruments, and the controls are an issue also, selecting the right control group. This happens to be women with breast cancer that didn't receive chemotherapy. And you can see that neurocognitive function improves. But there's a big caveat. Although neurocognitive function improves, there's a disconnect between the symptoms people are experiencing and these performance on neurocognitive testing. And that's been a theme throughout the literature that, maybe we're not measuring the right questions, not asking the right questions, making them perform the right tasks, because they're still complaining, but despite improvements on these testing. So this is a recent meta-analysis summing up the cross-sectional studies. That's one point in time. You take survivors who were treated with chemotherapy and survivors who weren't treated with chemotherapy and put them through a cognitive testing. Or you take prospective longitudinal studies. And the cross-sectional studies, which is the weaker evidence, seem to show the effect more in attention, executive function. And this is a forest plot, interpreting these. To the left of the line is an effect. So they seem to have an effect on attention, executive function, motor function, processing speed, short-term memory. But the more valid studies, the higher level evidence, would normally come from prospective longitudinal studies, and then the data is really not there in terms of no significant difference. In fact, you would conclude from this data that long-term memory is improved by chemotherapy, and that's obviously not true. So I think that this speaks to the difficulty of studying this clinically. There's no validated set of instruments in neurocognitive testing. The baseline function is variable. The populations are variable. This contributes to a mixture of results and leads to a result like a null result on the meta-analysis. Probably the most compelling evidence is the functional MRI studies. And this is one example. Identical twins, one gets breast cancer, one gets chemotherapy, the other doesn't. And you can see clearly, graphically, different areas of the brain light up, and there are structural changes and metabolic changes going on during chemotherapy. So this is compelling to say that chemotherapy is having some effect on brain function. So what do you do about this? Well, there's a lot you can do about neurocognitive dysfunction, relaxation training, compensatory strategies. There's lumosity and things like that. There's self-instruction training, time management training, fatigue management training, and problem-solving training. So there's a lot to do to compensate, and compensating strategies for these people that are affected with neurocognitive function. So my summary of this part of the slide is the problem is very difficult to study. What is the baseline and when do you measure it? Post-chemotherapy, we think neurocognitive dysfunction occurs in about 15 to 20% of patients. Probably the most compelling evidence is the imaging evidence that suggests structural and metabolic changes in the brain. Genetics, as in all things, has a lot to do with it, I think, and additional research is needed, obviously, on this problem. So I was, in my last year of Ohio State, I was part of a group that tried to model this in mice. And we gave mice the near equivalent doses that we give with standard chemotherapy with cyclophosphamide and doxorubicin. And we assessed depressive behavior, anxiety behavior, and cognitive deficits. And you can do these in mice in very interesting ways. So depressive behavior is assessed by the amount of time the mouse spends floating in a tank. And I don't know, but that's how it is. Floating behavior. And the shorter latency to float and the amount of time spent floating is an indicator of depression. And chemotherapy exposure causes less time to initiate floating and more time spent floating. Anxiety, rodents don't like open spaces, so you can assess anxiety-like behavior as associated with an increased latency to enter the open arm and a decreased total time spent in the open. And this is a graphic control and the chemotherapy treated, and they spent less time in open spaces, indicating they had a lot of anxiety. And finally, this contraption is called a Barnes maze. It's a series of circular discs, and one disc has a hole in it, and the mice try to find the hole because they try to avoid open spaces. And it's the latency to find the hole, the time it takes to find the hole, the distance traveled, and the number of errors they make along the way. And increased latency and errors are associated with cognitive defects. And so chemotherapy impairs, but does not prevent learning the Barnes maze. It increases the latency, suggesting there's a cognitive effect going on, deficit, but it doesn't impair the learning with repetitive trials. So based on this, we thought that this was pretty good, that chemotherapy in mice could mimic the symptoms that people experience, depressive-like symptoms, anxiety-like symptoms, and cognitive deficits. And we had a hypothesis, which I can't get into, but it's basically microglial activation in the brain causing neuroinflammation by secretion of cytokines we thought contributed to this problem. And we're going to design a clinical trial to test this hypothesis. So what's going on, and I could speak for more than this talk allows, the Survivorship Committee at Mount Sinai. So there's 4 subcommittees, and the emphasis has really been on getting those treatment summaries and individualized care plans going. The Commission on Cancer, which is the American Surgeons of College accrediting body, has metrics. The metric is, by 2019, all cancer patients treated with curative intent will have a ASCO summary, treatment summary, and an individualized care plan. And we've spent time embedding them site-specific in EPIC. They can be self-populated if you put the right information in along the way. So that's what we've spent the bulk of our time recently, because we were having a site visit. But there's other aspects. There's a subcommittee on collating resources. In other words, throughout this health system, and this is social worker driven primarily, different social workers and different groups have different resources. And I had a vision of putting them all together, eliminating the redundancy, and really creating a resource for survivors. And probably the most important thing is the models of care. And we just had an initial meeting about planning a research feasibility study on integration of the oncologist and primary care physician in a models of care study where patient outcomes and quality of life would be measured. If this is positive, if the patients like the shared care model, the next step is a randomized trial with the intervention being shared care and the control group being usual care. And I predict that would be positive. And then there's a research committee charged with getting research going across the health system. I'm involved in a protocol that's nearly complete about optimism and resiliency, and the hypothesis is that the more optimistic you are, the more resilient you are at baseline, the less chemotherapy side effects you will have. And we're going to test that hypothesis formally in a trial. So my overall summary is survivorship is an academic opportunity. If any residents are in the audience, this is your chance, because it's a growing opportunity. There's tons of work to do. There's not bad in the funding realm as well. There's specialized sessions like NCAM and NCI that support this type of work. And by nature of a growing population. It's growing in importance. By 2020, there'll be 20 million survivors in the US, the majority over 65. So as I mentioned before, geriatric survivorship is the new thing. So I think all-encompassing definition is empowering patients to chart their own path to wellness after cancer and its treatment. There are tons of guidelines, ASCO, American Society of Clinical Oncology, American Cancer Society, National Comprehensive Cancer Center Network, and so forth and so on. We spent hundreds of, not thousands of man-hours formulating these guidelines for recommendations, but we don't do enough to assess their impact on practice. COPE and COPE certification, we've just been granted COPE certification in this institute as a quality metric for insurance party, third-party reimbursement. The COPE, they'd like to see that you have COPE certification. Randy Hokum and his GI group had it 2 years ago. So it's the thing you do to show that you're delivering high-quality care, but it has limitations as well. But it's about the only thing that reliably gets you into how pervasive your recommendations are being followed in actual practice. And I just was part of an effort to develop a survivorship core curriculum competencies for residency training programs, health policy organizations. Survivorship content is out there, but it's fragmented, it's incomplete. You look a lot of places for it, and we put together one document with survivorship, the core competencies and core curriculum that just got accepted in the Journal of Oncology Practice. So my conclusion is, don't lose the forest for the trees. Don't. It's turning out that the treatment period, active treatment period for many survivors is a small part of a long life, and we've got to pay attention to the things we do and programs we develop for survivors in general. And shared care model, I can't overemphasize that enough, in my opinion, delivers the best care that's possible for survivors. Thank you very much.
Questions?
Congratulations on a gentle approach to a not so gentle subject. About the brain, do you have a control as to the impact of the diagnosis of cancer on people even without chemotherapy?
So I think that you can imagine that's a stressful time. You can imagine you ask the question, do you have a control about people before chemotherapy? And you can imagine that cancer diagnosis is a stressful time. So all the stress and anxiety, depression may lead to reporting neurocognitive problems in general on these instruments.
You talked about shared care. Is that another term for co-location of services? And if so, is there literature on co-location of services?
So
how well they
I think that the question is there shared care as co-location of services? And there's clinics, survivorship clinics, that have physical experts, oncologists, primary care physicians, endocrinologists, et cetera, cardiologists in one place. I don't think that's the most efficient way to do it. It's really good for the patient, but in terms of everybody's time commitment, it's really inefficient in terms of time. So I was more envisioning a shared care model where the transition would be, say, you meet the primary doctor, initial aspects of treatment, and then gradually, as they go through the treatment, they might see the primary care provider once or twice, but the transition is from active oncology to primary care, and the roles will reverse. The primary care physician will do all the health maintenance, and they'll see their oncologist maybe once a year. So that's the kind of model I'm thinking about. Yes?
So I think that what you're doing is very important, but I want to give a couple caveats. One is that on the mouse studies, there certainly are things that you can measure, but if you were measuring some of the same things on somebody from the Czech Republic who speaks no language in common with you, you would be at a disadvantage and could only measure certain things, and you don't speak mouse, I'm sure. Secondly, if you look at the functional MRIs, that was very interesting, comparing identical twins, one with cancer and one without. But since you're talking about survivorship, you would like to look not only before, but also a couple years after a cure.
So to your first point, that's the whole realm of tailoring your message to the group in question. So I agree completely that we have to have tailored messages for different groups. Spanish speaking is prevalent here, and we have to tailor it to the Hispanic community, all these services. Now, this is interesting in terms of acute changes of chemotherapy on the brain. There's little in the way of longitudinally following up these changes. I do know that there's permanent, some studies suggest permanent structural changes in the brain due to chemotherapy, but that's really not well developed yet in the literature. Yeah, good.
I was wondering how much use you're making of modern day technology. For example, in response to his question about language problems, I was just asked to review an interview with a mathematician in Russia, and I had the choice of making an instantaneous selection of a translation. The translation was not great, but it's available now. And so with the use of technology, you have the ability of giving every single individual patient access, for example, to a website, which will give all of the pages of information that we try to discuss individually with our patients. So I was wondering if you're using our apps and applications of modern technology to help you do what you want to do, including your studies.
So that's a great idea. We would welcome the use of technology. We're in our infancy. We've had one meeting about this shared care model, one meeting. So anybody, I invite anybody who's interested in developing this with us. And I'm not talking about the patient who has an established primary care provider. We're not interested in that. But many people don't have a primary care provider or are not satisfied with the primary care provider they have. So these are the people we're targeting for the shared care model. We don't want to take patients from anybody. But you're right, technology, and more we can use technology, the better off we are. And we're using iPads to self-administer questions to patients in the waiting room. So we're doing some of that.
One last question.
I was just wondering if you could clarify one of your summary points at the very end. You said your goal is empowering individuals to take back control and chart their own path to wellness. I guess I'm having a hard time with that and putting that with the Livestrong survey results that 70% did not have enough support.
So that is a sad commentary on the job we're doing, but I have an expectation that we can do better. We have to empower them by giving them the tools, and it could be a different prescription for different individuals. Not all survivors have the same spectrum of needs, and the needs change over time. So I'm saying that we should emphasize empowering individuals to give them the tools they need to chart their own path, whatever it is, to wellness. But I agree with you, that's a sad commentary, and it's pretty much true today, that we don't know about, we don't have time to address these questions. And we don't have the information fully to address the questions.